I'm not too sure if you've delivered any babies yet, but you soon will, or maybe you have delivered your own or somebody's baby that you were close to. If you have delivered babies and they came out with a heart rate of over 100 and they were crying and fussing and their arms and legs were moving around and they coughed or sneezed when you put a catheter in their nostril and they were pink, then these are babies that have an APGAR score of 10 because they get 2 points for every one of these 5 things we mentioned. APGAR is amazingly not only a good acronym to describe these 5 phenomena: appearance, pulse, grimace, activity, and respiration, but amazingly it also happens to be the name of the doctor who developed the scale in 1953, Virginia APGAR. It has been used as the standard, undisputed standard by which we measure newborn health, and the APGAR score, which you could see is a maximum of 10 or a minimum of 0, which would be probably stillborn, is the scale by which babies are judged to be healthy. So at some point in time, you won't even have to remember these things because you'll be doing them every single day. Many studies have been done to look at APGAR scores of newborn and relate them not only to mortality, but to things further on in life. Basically, every APGAR score over a 7 has almost a 0% mortality in the immediate perinatal period, and specifically 28 days as the cutoff point. An APGAR score of 0 to 1 has a 50% mortality at 28 days, and usually very, very quickly. And of course, an APGAR score of, let's say, 4 has a 20% mortality. So as you can see, this is a scale relating APGAR score to mortality, but so much more, even things like intelligence and achievement, and there have been a million APGAR studies that have been done. Babies are sterile, perfectly uninfected organisms. They can get infections, though, perinatal, starting out prenatal. They could basically only get them 2 ways. One of them is through an ascending transcervical infection from the mother, usually due to inhalation of infected amniotic fluid, very closely related to a premature rupture of membranes, or passage through a birth canal during birth. Women with herpes is likely to have a C-section for that reason. The only other possible way a baby can become infected, if it wasn't through the transcervical route, it would have to be hematogenous, and as you know, the placenta is the big thing between the mother's blood and the baby's blood, so hematogenous infections are also known as transplacental. They're mostly viral and parasitic, and that's where the name torch comes from, with everything in the torch being a virus other than T, which is toxoplasma, and O, which is other. But rubella, CMV, herpes, those are the transplacental infections. Another virus, parvovirus B19, fifth disease, has a disease called erythema infectiosum, which looks like a real big, puffy, red infection, which is manifested in cheeks and other places, as another thing. The single biggest bacteria for a transplacental hematogenous infection is Listeria. Remember, it was one of those things that we called a gram-positive rod, and this is the single biggest bacteria infection for placental infection for babies. When you look at the development of the baby's lungs, histologically or conceptually or both, you will realize that as the lungs develop and as the air spaces become bigger, there is then a change in ratio between the air cross-sectional area or volume and the stroma or connective tissue around it. And as the lung develops, not only do these terminal alveolar sacs get bigger, but the epithelium lining them gets thinner, and the blood vessels grow more intimately into relationship with these thin alveolar cells, both type 1 and type 2 pneumocytes, with type 1 being the predominant cell. The thing to remember, however, that in this histologic development, the key factor, the key thing secreted both from the type 2 pneumocytes as well as the Clara cells, if you remember the Clara cells from the epithelium higher than the respiratory bronchioles, is surfactant. So problems with fetal lung maturation are due to inadequate surfactant. That's clearly established. And they produce a disease called neonatal respiratory distress syndrome, RDS. And remember, that is to be differentiated from adult respiratory distress syndrome, which is completely another disease which we have talked about already, and we will talk about some more. RDS is one of the biggest killers of newborns. It's 60,000 cases a year in the USA, 5,000 deaths. Its incidence is inversely proportional to its gestational age. So the more premature a baby is, the more likely it will have RDS. And the single biggest survival problem with prematures is respiratory, and that's all because of lack of surfactant. When the baby takes that first breath, if you've delivered babies, at that point the surfactant is really pumped out in great amounts, and the second breath and the third breath is therefore easier and easier. Without surfactants, every inhalation is like the first one. It's very, very, very difficult to do. What surfactant does is it decreases surface tension such that the babies can breathe better and easier with successive breaths. The three biggest risk factors, one of which we've already gone into for RDS, is prematurity. The more premature, the more problem there's going to be with respiratory surfactant. Diabetes independently is another risk factor, and so is a C-section, because there's something about the normal delivery process that stimulates surface surfactant secretion. So a C-section is more likely or less likely to produce adequate surfactant. If you've seen lungs for babies that died of RDS, also known as hyaline membrane disease, they're exactly the same disease. In the old days, it was called hyaline membrane disease, HMD. Now it's called RDS. The basic test we did when we did autopsies on these babies are to take the lungs and put them in water and see if they sink or float. If they sink, that means they didn't have much air in them, and that means the baby never really got a chance to inspire much air because of RDS. If they floated, that was one overall really, really good way to differentiate as a quick little test for RDS. Microscopically, and the reason why the disease was called HMD is that when you look at the lungs, there's a relative lack of inflammation. It's not an inflammatory disease. It's even though you will see exudates of fibrin and perhaps some cell debris which line the alveoli, and those are the hyaline membranes. And this is what hyaline membrane disease looks like, or HMD. Look, it's a lung. It's not very well aerated, but you can see some bronchial mucosa here, can't you? You can see some blood vessels. You can see that there's not much cross-sectional air in this lung. This might be something that may not have floated. But in addition, look at some of these larger alveoli. We'll go up a little bit further, and look, you have hyalinized or pink eosinophilic material. That's the definition of hyaline, is anything with H&E that is pink and amorphous and acellular and eosinophilic. That's the definition. In this case, hyaline membrane disease are composed of fibrin and also of probably some degenerated cells from the alveoli, some pneumocytes and so forth. We'll go into the next clip very soon. I thank you very much.